Good evening, one and all. I'm Karan Sharma, and on behalf of FDC, the makers of ItCoFort, I welcome you all to the 13th episode of the Sunday 9 p.m. show of Iron Talks. Here on Iron Talks, we discuss anemia and how its presence in your patients affects your patient's well being. Your patient may be healthy or may be suffering from a comorbidity, where anemia could affect the approach of how you choose to treat such patients, or for that matter, even the maintenance of your patients. We have been fortunate enough to have learned scholars of medicine to discuss and throw light on such varied topics of anemia from across the country who've graduated and are now practicing at such prestigious institutions like CMC Vellore, some from Osmania College of Medicine, Hyderabad, while some from the distinguished AIMS Institute, New Delhi. Without further ado, let me call upon stage the reason why Iron Talks was founded and brought to you on this platform, who so selflessly brought to you such profound speakers, a towering personality from the Indian medical fraternity, a DM endocrinologist from the prestigious AIMS Institute, New Delhi, and a very down to earth, a humble but one of the most learned persons I have ever known. Ladies and gentlemen, please give it up for your host for the night, Dr. Sanjay Kal. Good evening, sir.
Good evening, Karan. How are you? And thank you for your kind words.
Thank you so much, sir. And sir, we are again pleasured and we have the pleasure to have you on the stage once again. So the stage is all yours, sir.
Thank you, Karan, and greetings. Good evening to everybody who is logged in with us today. For me, it is a matter of pride to be able to introduce someone whom I feel is the epitome of a physician, the way a physician should be. And I would also like to thank all of you for having asked so many questions over the past 3 months. And many of the questions, especially I remember Dr. Javed Iqbal from Srinagar, the questions stimulated us to request Dr. Pavan Rawal to come and speak to us about anemia and gastrointestinal disorders. So, warm welcome, Dr. Pavan. Dr. Pavan Rawal is a gastroenterologist at Artemis Hospital in Gurgaon, Haryana. Uh, we can speak, forever and ever. We can continue speaking about the definition of a good doctor. We can continue speaking about what a person-centered, a patient-centered doctor means, and we can also talk at length about what a technology-savvy doctor is. But instead of doing all that, why not let's just listen to Dr. Pavan? He's a perfect balance of being technology-savvy and also person-centric. He's graduated from PGIMS Rohtak and then done his fellowship in gastroenterology from PGI Chandigarh. More than one and a half decades of experience, and you will find that he is the best teacher you would ever encounter. So I'd like to invite everyone to listen to his talk and feel free to ask as many questions as you can, especially Dr. Javed, all the difficult questions that you've been asking over the past few weeks and which you've not been able to answer. Here we have Dr. Rawal with us. So he'll help us out in all the questions for anemia related to GI disease and also related to liver disease. So Dr. Pavan, warm welcome to Iron Talks.
Thank you, sir. Actually, at the outset, you have increased my responsibility to very high level. You know, but then again, thank you, FDC, for arranging this talk. I've always enjoyed talking to Dr. Kalra and his presentations, his organization skills. I've already checked previously also. It has been always wonderful, doing the seminars, the webinars, and the talks with you, sir. Thank you again, sir, for having me here. So, should I start?
Yes, sure.
Yeah. So, very interesting topic indeed. The GI and the anemia. Very close to my heart as well, because we all believe that the GI is a very, very common site, I would say, where the iron deficiency or the deficiency of hemoglobin may happen. We will discuss about this at length. Maybe it can be very interactive as well. At the outset, I just would say we keep on getting referrals for the patients with low hemoglobin very, very frequently, even though there is no overt or occult cause, or even though there is no melena, hematochezia, hematomasis, or anything else. We commonly get the referral for finding the cause of anemia. And yes, we are successful in 50 to 70% of the patients where we go for a particular cause rather than only supplementing iron as the others would do sometimes. Now, once we talk about anemia, we know anemia results from either it's a defective production or increased destruction or loss. As like any deficiency, if you don't take the food or the iron, If that is not absorbed, so there is malabsorption. If it is not produced in the bone marrow, it is destructed or it is lost. These are the possible causes of anemia, as would expect. We usually classify the anemia by red cell indices. When you, as a physician especially, once you approach anemia, the first and foremost classification comes by red cell indices, especially the mean corpuscular volume. And by MCV, you will actually classify into it microcytic, normocytic, and macrocytic. That will at least give a kind of clue where probably we should lead to, or it will tell us the possible approach to that particular anemia. Now, most commonly we talk about microcytosis, and today's talk also would be more focusing on the microcytic anemia rather than the macrocytic or other causes the anemia. So microcytosis, that would mean be a low MCV, is characteristic of iron deficiency anemia. But one should be cautious. The MCV low or microcytosis can be present in thalassemia and other causes as well, wherein the low MCV is out of proportionate to the anemia. So do have a caution here. If MCV is actually out of proportionate to anemia, you may be dealing with case of thalassemia, and the hemoglobin electrophoresis may give us diagnosis. So just a word of caution before you start proceeding for so many causes, and this you keep on searching the causes of low iron or the iron deficiency anemia. So for the first presentation, this slide, I would summarize. First, approach a person with low hemoglobin. Try and classify it with the red cell indices, particularly the MCV. The second could be RDW, that's red cell distribution width. Try and classify into microcytic, normocytic, macrocytic. Microcytic, we know the commonest is IDA, iron deficiency anemia. If there is an associated increased RDW, that means the red cell distribution width is more. And that literally means that the distribution width of red cell is of various types, from low to moderate to high. So this will probably indicate that there is some associated B12 or folate deficiency also. So there's a kind of dimorphic picture you will be getting. So this will make a clue to this, and this can happen in generalized malabsorption, especially of the intestinal origins. Now, serum markers of the iron deficiency anemia, we check for serum iron, which should be low. We check for the serum ferritin, which should be low, and the TIBC should be high. So this is classical almost of the iron deficiency anemia. Now, common peripheral smear finding. I love this thing called peripheral smear, because once you start approaching a patient of anemia, especially with the possibility of IDA, the MCV, RDW, and peripheral smear, they should be ordered as a must. They will tell you so many things which even the endoscopy, colonoscopy, the enterography or capsule endoscopy may not tell. So don't miss this initial process of at least making an approach to a possible cause. So do order a complete CBC, ESR, and peripheral smear. Peripheral smear may tell us so many things, especially in the hands of a good hematologist or even kind of physician. We can have so many things in hand. So we may find different kind of peripheral smear, especially once you talk of anemia because of GI tract. This could be kind of hypochromia with sideroblast, where it signifies the sideroblastic anemia, but MCV would be low. There is a term called Zeev syndrome. I'll talk about it. This happens in alcoholics, especially they present with the hemolysis in the setting of jaundice. So since there is hemolysis, you will find the red cell fragments. You may find pancytopenia, especially if there is chronic liver disease with hypersplenism. You may have pancytopenia because of bone marrow suppression. That also may happen because of alcoholism. Between B12 and folate deficiency, of course, can be found, and iron deficiency we have talked about. So do order a good CBC, ESR, and peripheral smear. That will help us approach the person. Now, once we talk of iron deficiency anemia, the IBD is one of the commonest causes once we talk of GI tract. Now, WHO has said that approximately 30%, though this data is much variable, and data has, the variability goes from 10% to 30%. They say that 10 to 30% of the population can have iron deficiency anemia. 1/3 of the IBD patient can have current anemia. Though this is kind of moderation, I would say more people have anemia in IBD, but then 30% is the data which is available. Now let's approach as a GI condition. So what are the GI conditions that can lead to iron deficiency anemia? As we already discussed, the anemia happens because of decreased intake, malabsorption, poor production, increased loss, and hemolysis or the destruction. So once we talk of GI, of course, we all know that GI is a very, very common site where absorption would happen. So malabsorption henceforth is the one of the commonest cause leading to IDA. What are the possible malabsorption which can encounter? IBD, as we discussed, especially the Crohn's disease. Why Crohn's disease? Because Crohn's disease is the IBD which affects the early part of small intestine also, like duodenum and jejunum, where most of the absorption would happen. So Crohn's disease would cause more anemia as compared to ulcerative colitis, because in that case, the anemia is usually due to blood loss because of the bleeding. Celiac disease, as our experience also says, it's becoming more and more common cause of anemia. Dr. Kalra will agree. I mean, we now diagnose so many celiac disease. The prevalence has gone up to 1 in 100, especially in this part of the India. Some kind of surgeries where you bypass the stomach or the duodenum would lead to anemia. H. pylori colonization leading to H. pylori gastritis also is one of the common causes these days, and more picked as well. Gastritis, autoimmune, and other diseases can also lead to malabsorptions. I've not, written so many other causes like tropical sprue and intestinopathies and the other things because of the uncommon nature of the disease. Now, blood loss can happen. Blood loss can happen because of the cancers. Have not labeled esophageal, gastric, pancreatic, intestinal, small intestinal, and pylori and colonic cancers. They all can cause it. Various kind of tumors, especially adenocarcinoma as the neuroendocrine tumor, all may cause. Peptic ulcer disease, common cause. Chronic liver disease leading to the portal hypertensive gastropathy and gastric enteral vascular ectasia can lead to anemia. NSAID use, we all know, can cause occult blood loss, especially, and the other things like angiodysplasia and worm infestation, no more to mention. So we can see that GI diseases represent the most frequent cause of IDA, especially in the middle and the senior age groups. The mechanism we discussed: malabsorption, malnutrition, losses. Losses can be upper GI blood loss and the lower GI blood loss. And the causes we have seen. Now, why we are talking about IDA? Because iron is very essential cellular component. Once you have iron deficiency, it results in mitochondrial dysfunction. It decreases the enzymatic activity, and of course, it actually decreases the transport, and the structural protein apoptosis increases. There is effect on tissue remodeling. There is impaired organ efficacy. And of course, it leads to further exercise immobility or a decreased capacity to exercise, reduce work efficiency, and there are so many things like impaired cognitive performance, behavior, etc. And of course, finally leading to increased morbidity and mortality. So we all agree that we need to correct iron deficiency if it is there. Now, clinical consequences of this cellular dysfunction could be at any level. They start from the head, scalp, and they go to the feet. So, manifestation can happen any level. I'm not going in detail. Everybody knows. The commonest could be like patient have fatigue, their lightheadedness, headache, lack of concentration, lack of, exercise. And then there are so many morphological changes that may happen. There can be GI changes, there can be nail changes, and so many things that may happen because of the anemia. How do we approach? It starts with the basic, as I discussed. Do order a complete blood count. You may not even send the patient to GI if you do this. Complete blood count with peripheral smear will tell us so many things. I mean, before we guys are into picture, this should be there, so that at least we classify the patient into the type of anemia, and we at least have an approach whether we should go for a GI evaluation or not. Especially GI evaluation actually requires a lot of efforts. Knowing the endoscopy, colonoscopy, or small bowel evaluation is a tedious task. It carries some risk also, especially in elderly population. So this is the initial set of investigation we should order, which include the CBC, MCV, peripheral smear, classify into the microcytosis, hypochremia, other types. Yes, we confirm it with the serum ferritin. Serum ferritin is a very sensitive marker. Though serum ferritin also is acute phase reactant, it may be increased in inflammatory, the malignant, and the other conditions. Of course, it can be high in the chronic renal failure as well, but still serum ferritin is a very, very important marker where it helps in classifying the type of anemia. We can order the other tests like reticulocyte count, vitamin B12 and folic acid levels, especially if we are thinking that we have a dimorphic kind of picture, or there are some setting where the B12 or folic acid deficiency may happen, or the RDW is high. So we can order these as well. Especially if I talk as a GI specialist, we try to screen the patient for celiac disease at the outset. And believe me, now age is not a parameter. We have diagnosed celiac disease from the early childhood, and we have published a lot on celiac for that matter, and even till late ages. Especially the celiac disease can be latent in these kind of population, and the manifestation will be just in the form of anemia, even in the absence of loose motions and other things. So just look for TTG, IgA level, or the other parameters serologically, and if needed, do an upper endoscopy and D2 biopsy. That's the duodenum biopsy to confirm the celiac disease. So once you are doing an endoscopy, we can check for the H. pylori by taking the enteral biopsy. We have rapid urease tests available, and so we either do RUT or we send the sample for the histopathological examination, and we look for H. pylori, and we treat or eradicate if it is found. Now, usually the upper endoscopy and colonoscopy, they are performed once the patient is sent for the GI evaluation as a cause of IDA or emergency anemia. Now, there are certain debates which say that whether they should be performed together, they should be performed by one, but especially in postmenopausal women, we tend to perform both together because it decreases the patient discomfort and the number of hospital visits as well. If we talk of lower GI tract, colonoscopy is the preferred method at present. Barium enema and other kind investigations probably are now fading off because of lack of sensitivity. Up to Even after this, up to 50% of the patient may not have some identifiable cause, and this would happen more when there was no overt bleeding. So that means if there is no melena or hematochezia or hematomasis, the cause may not be found by just doing the upper endoscopy and the colonoscopy. Some people ask about stool for occult blood testing. The sensitivity of stool occult blood testing in the best of the examination, and even after 3 samples, is around 50 to 60%. So it usually has not changed our decision to manage the patient or to decide whether person should go for the endoscopic evaluation or not. They can be done, but whether they add to the treatment algorithm, it's not sure. Now, suppose you have done upper endoscopy examination and a colonoscopy, and you don't find anything. Further small bowel investigation can be performed. Usually, we go ahead with the small bowel examination with wireless capsule endoscopy. The BMFT, that's barium follow through. It's a investigation of the past now. Usually, we don't perform because of the lack of sensitivity and the tedious nature of the test. Capsule endoscopy allows visualization of the entire small bowel. A lot of comfort is there. There's no preparation usually, though we give Paglex sometimes. There's no sedation. Patient swallows the capsule, and it has very good diagnostic yield, which has varied from 31 to 76%. That it in case of obscure GI bleeding. I mean, suppose there was no source and location of the bleeding, even then it has diagnosed the cause in 30 to 76%. So once you have a cause or there is iron deficiency anemia, we will treat. So treatment goal is, of course, iron deficiency anemia leads to decreased quality of life. We need to improve that. We need to optimize hemoglobin level, preferably up to 14 gram, though there is debate on that as well. If there is associated vitamin B12 or folic acid deficiency, sorry for this typo, it's folic acid deficiency, appropriate substitution is needed because that also adds to the improvement. Once you know the cause, try to treat that because just supplementing iron will not help till the time you actually eradicate the root cause of the anemia. Iron supplementation can happen in the form of either oral or the intravenous iron preparations. And once we talk of, iron is best absorbed in the ferrous form in the duodenum and the jejunum. There can be some adverse effects like constipation, nausea. Occasionally, we have seen diarrhea as well, but the common one are the constipation and nausea. Of course, the color of the stool may change. Repletion of the iron store can take 6 months, so have a patience on that. Parenteral iron usually replaces iron store a little faster than its oral equivalent, but hematological response is similar. That's very important. So until the patient is not able to take iron orally or there is some urgent situation, the parenteral iron may not be indicated, though it usually replaces the stores faster. There is small risk of anaphylaxis with the IV preparations, especially, but the newer preparations like this maltose one has a significant low risk of the anaphylaxis. Some role of recombinant human erythropoietin. So I won't go in detail with this because it's more for the supplementation. Suggested approach for the assessment is if hemoglobin is less than 12 in women and 13 in men, you label it as anemia. Look for ferritin. because you have to rule out, or you have to think of the anemia of chronic disease as well, where the ferritin levels are okay, but the utilization of the ferritin to iron is not there. So you have to see ferritin as well. If the hemoglobin is around 7 to 10, uh, and it's required, you can go for IV iron as well. Otherwise, look for inflammation, look for CRP. And if there is no inflammation, because the ferritin is a acute phase reactant, so good, look for the go for the oral iron. If hemoglobin is less than 7 and there are clinical symptoms, preferably go for transfusion, because that's a required one, especially if there are cardiorespiratory conditions or there are comorbidities present. So transfuse blood, it's required. If there are no significant clinical symptom, that is, the anemia is not symptomatic, of course, then you can choose between oral and IV. But some people recommend that if the hemoglobin is less than 7, for a faster supplementation, IV iron can be given. So that is one is preferred. Of course, we tend to treat the root cause as well, and we believe especially that's more important, because just supplementing iron may lead to the good level, good quality of life for a few months, but then again the things may turn back to the same pavilion. So this is usually the approaches. The other causes of anemia are there, which can be related to GI tract. I'm not going to go in detail because the target was more towards microcytic and IDA. So anemia of chronic disease, especially like tuberculosis of the intestine or the IBD, can be the common situations where the anemia of chronic disease may happen. So if we talk of IBD, vice versa, it can lead to anemia of chronic disease. It can lead to iron deficiency anemia. It can lead to decreased intake because usually the pain is there. There is some malabsorption in Crohn's disease because of the cytokine effect. The losses are always there because of the ulcers, and there is some bone marrow suppression as well. So in IBD, the anemia is multifactorial. Macrocytic anemia can happen in alcoholics because of the deficiencies, we all know, and especially if there is only alcohol excess as well. We know MCV is quite high if there is significant alcoholism. Hypothyroidism also contribute to the same. Zeev syndrome, as we talked about previously as well, it consists of syndrome where the jaundice is there along with hepatic dysfunction, hyperlipidemia, and there is hemolytic anemia. Especially it happens with the alcohol excess. So one should have a, we know the prevalence of alcoholism in this part of the country. So just look for Zeev syndrome and look for reticulocyte count and hemolytic anemia if you're finding jaundice and a severe anemia, especially in alcoholics, or if they are presenting with alcoholic hepatitis. Anemia may happen because of other causes as well, and now since the bariatric surgery is coming up, almost all the patients, they, especially the gastric bypass, they present with the anemia. So these are the other causes of anemia related to GI tract. So this is, I just wanted to say, and I think I should conclude. Thank you for the patient listening.
Thank you, Dr. Pawan, and you've made such a complex topic so simple. I had a friendly question. How long is the gastrointestinal tract?
So that's a difficult question actually. The GI tract length is so much variable, but yes, it has varied from around 10 to 14 feet. But then it has been studied actually, this concept, but it has varied from 10 to 14 feet. Just to tell that small intestine is the lengthiest part. So though it's called small intestine, it's not small actually. The diameter is small. Colon is around 3 feet, and from esophagus to duodenum is around 1 to 1.5 feet.
So in just about 20 minutes or so, you actually covered the entire span of the intestine. And lots of comments coming in for you. Lots of gratitude from Dr. Anshul Singhai from Bhilai. Let's take the questions one by one. A clinical scenario shared by Dr. Muke. Hemoglobin is 17.28, which is quite good, but the iron is low and the ferritin is low. So first question is this possible?
Yes, sir.
You
It's
can have,
possible.
yeah.
Yeah.
So it is quite possible, and this is sharing with everybody. You can have subclinical kind of an iron deficiency. So the iron will be low, but it has not manifested yet. It has not manifested yet in terms of a low hemoglobin, in terms of anemia. If you don't do anything about it, it may later on, and there may be symptoms, vague symptoms. Now, Dr. Mew goes on with the explanation. JAK2 and V617F mutation is negative.
Mm.
Erythropoietin is also normal, 16.5.
Mhm.
The only significant history that he's been able to find out is that the patient has GERD and has been on chronic proton pump inhibitor therapy forever and ever.
Mm.
Can PPI therapy lead to iron deficiency?
Yeah, excellent. Actually, this very situation. So it's like a home. I mean, there are situations in home where the stores are not there enough, but we still get chapatis. So ferritin like that. Sometimes the ferritin is less, but body is able to manage the hemoglobin. So that can happen. So this situation can happen where anemia may not be there, but ferritin stores may be less in few people. Actually, this is the physiological process. Accordingly, the anemia happens later on. This is one. Second, yes, I mean, if JAK2, I mean, PNH workup is negative and the GRD is there and PFN and PPI. Now, this is a very excellent question because PPI can cause anemia because of various causes. The commonest is not actually iron deficiency, commonest is B12 deficiency. B12 requires a R binder in the stomach where which requires acid for the in the action. So if there is decreased acid, the R binder may not work and the B12 deficiency may happen. There has been a lot of data for B12 deficiency, and the if you talk of the odds ratio OR or the RR, the relative risk, it is moderate. It's not significant, but it's moderate. It's around 1.5 to 1.8. So yes, it may happen, but yes, the iron deficiency is not that common with PPI, especially with the use less than few months. You require to take PPI for years before you start thinking that the anemia is because of the PPI.
So PPI therapy and metformin therapy both can lead to vitamin B12 deficiency.
Yeah.
And if this is on top of a patient's diet, vegan or vegetarian, then we actually may get in trouble. So be careful. But what Dr. Rawal is trying to tell us is that in this particular patient, the iron is low. That will not be because of PPI. Low vitamin B12 may be because of that. And even with low vitamin B12, it is possible that you have a subclinical deficiency. You may have neurological manifestations, you may have hematological, you may have both, you may have none of the above. So keep an open mind. Dr. Nitin Rola says, after eating food, I feel sleepy. Is this because of indigestion? Is it because of low sugar? Is it because of high sugar? Is there anything in the GIT which makes us sleepy after eating a meal, especially a tasty meal?
Yeah, so blood is limited. It's 5 liters. So once you start digestion, the blood is preferably circulated to the GI tracts. So there is some diversion of blood from the brain. So some kind of fogginess, or it may happen because of the heavy meals, especially. So this kind of scenario happens because the blood is now circulated more in the GI tract for digestion.
And I think basically what your body is telling you is that you are eating beyond the capacity to digest. So try to reduce your intake, and maybe you can stagger it over a few hours. You can have a 3+3 meal pattern instead of having three major meals. In the gastro OPD, Dr. Pavan, just offhand, there is something known as postprandial angina. Do you
Mm.
come across patients as a gastroenterologist where you take a history and then you have to say, sir, maybe I'm not the right doctor for you. We need to get a cardiac evaluation done. Has this happened in your OPD? And what kind of
So
symptoms would the patient share?
yeah, so it's more of a theory actually. The clinical presentations are not that common. This is number one. This is known, I mean, because there is a steel phenomena in this case. But then, yeah, clinical presentations are less common. I would not encounter even one case in 6 months for this kind of scenario. So extremely uncommon situation. There is usually some risk factors which are there in these patients. It's not a common one which we see.
And reactive hypoglycemia, this is something that we are able to pick up quite frequently in a metabolic clinic as a physician. Does this present in the gastro OPD?
No, sir, it's you.
Okay.
Yeah, it will
So
go to
that
you,
could
sir.
be
I
another
mean, yeah.
cause of drowsiness, the point which Nitin raised. So it is possible that your patient complains of drowsiness or ghabrahat on the other hand, uneasiness. And that is because of low glucose. And again, the treatment is small, frequent meals. It means too much of food is being taken.
People should know that most of the department which belong to endocrinology is in the GI. Sir, GI is the most common source of hormones.
Yes, that's right. And also psychiatry. So, as a younger doctor, when patients would come and say, मेरे दिमाग को gas चढ़ती है, gas enters my head, I would laugh. And it's only recently that I learned that 90% of the serotonin in the body is produced by the gut, by our friendly bacteria in the gut. So, one of the highest selling medicines in the entire world, especially in USA, is serotonin uptake inhibitors. We are trying so hard pharmacologically, to improve our serotonin levels, while actually you can do it just by modulating your diet. So, Dr. Pavan, what is the best, the simplest advice you would give for a happy gut and for happy serotonin producing bacteria in the gut?
Sir, curd. Yeah. So basically, curd is a very good source. So it's one should love it. Rather, I would encourage more curd, yogurts, and buttermilk as compared to the milk itself as a dairy substitute if you want. Yeah. Other than that, the usual diets we usually talk about, Mediterranean diet or the diet which is less in fat and more in fibers. The fibers also stimulate the same.
And that clearly tells us which state of India Dr. Pavan Rawal is from, jo doodh dahi ka khana. So that is quite easy to guess then, Dr. Pavan, which state you are from. Thanks. One more question from Dr. Vinit Desai. Spot test for H. pylori.
Hmm.
Is this always done when you're doing an upper GI endoscopy, or do you decide it after you have viewed the stomach? What is the protocol these days?
Yeah, excellent question, sir. Because 40 to 50% of population is colonized by H. pylori. So it's very difficult to actually decide algorithm whom should be treated. So, but we, and of course, notice me that there is guidelines are if a person has symptoms which probably correlate to H. pylori gastritis, and if we are doing endoscopy for anything else, we don't do endoscopy just to check H. pylori. This is number one. We do endoscopy if it is really indicated, but if you are doing endoscopy for anything, you find the macroscopic picture suggestive of H. pylori gastritis, then you take enteral biopsies to rule out H. pylori. This is number one. But if you are doing endoscopy as an evaluation for anemia, we routinely test the H. pylori because the finding sometimes can be, the macroscopic finding can be subtle. So we always check for the H. pylori. And we test and treat rather than we treat randomly. So this is the policy we have.
One question coming from Chhattisgarh. Aspirin and gastritis, aspirin and anemia. How frequently do you see it, and is there a difference between the various aspirin preparations, immediate release and enteric coated?
Perfect. I mean, once we are talking aspirin, I should talk of clopidogrel as well, because that also is one of the commonly prescribed antiplatelets. Yeah, so aspirin can cause anemia, theoretically, okay. But the incidence as a, if we see as an isolated cause is not that common. This is number one. Usually aspirin will cause anemia when it is combined with other potential things like other NSAIDs or steroids or some associated, some like the person is smoking, there are stressors or something else we are taking. So isolated aspirin is not a very usual cause of anemia. If combined with other drugs which can potentially lead, like NSAID will lead to anemia together because the effect is more than synergistic. Clopidogrel will cause more GI side effect, especially the abnormal events like GI bleed. Let me be very specific here. It's not about talking gastritis. It's about talking abnormal events leading to GI bleed will be more with clopidogrel because of the systemic side effect rather than the topical side effect of the aspirin. So there is some myth that, if you give clopidogrel, the GI bleeding would be less, and if you give aspirin, the GI bleeding would be more. It's reverse actually. If you ask me which antiplatelet will you give if there is a potential GI bleed or the patient presents with GI bleed or I am doing some endoscopy procedure which has a potential to cause GI bleed, it's aspirin rather than clopidogrel. So yes, aspirin can cause anemia, but it is more when it's combined with some other cause.
Thanks. And again, from Dr. Anshul, I work in a setting where investigations are not available. For endoscopy, my patient has to travel 100 kilometers. So what is the significance of stool test?
Yeah, I actually talk in between. Yeah, stool, occult blood, especially. So suppose a patient approaches you and you diagnose it as iron deficiency anemia, possibility because of the low hemoglobin and low MCV. This is probably the scenario he wants to talk about. In that case, there is no overt bleeding or melena. That's why he is doubtful about endoscopy. If there would have been some bleeding, he would not have been doubtful about endoscopy. So this is a scenario probably we are talking about. So this is called as obscure bleeding or ID of GI cause where the overt bleeding is not there. Stool local blood has been used. 3 samples of stool occult blood will give you a sensitivity of 50 to 60%. So, I mean, I don't discourage doing it, but then stool occult blood will not change the decision to manage the patient and will not change the outcome most likely, even if it is negative or positive.
That point is well taken, and thanks for that. One question let me take, and also Dr. Pavan, greetings to you from Dr. Ajay Prasad, Dr. Monu Gurung. This patient that Dr. Desai says is a 48-year-old gentleman, 51 kg, so we assume a bit on the thinner side, diabetes plus COX. He is on ATT. He is also taking metformin 1 gram, which I think he should be able to tolerate, but not beyond that. We should certainly not increase the dose of metformin. He's on pioglitazone and insulin 8 units twice a day. Pioglitazone and insulin is it's not contraindicated, but it is something that we should be given very carefully. So do keep a close watch. If the patient has had such poor diabetes control that he has landed up with tuberculosis, it is possible that he will have other complications as well. And if you are using pioglitazone, one complication you have to rule out is proliferative retinopathy. So a fundus examination must be done. In the absence of that, what do we do? So Dr. Vinay asks, should I add vildagliptin? The answer is no. Let's ask Dr. Pavan. Dr. Pavan, ATT and the liver, anti-tubercular therapy and the liver, vildagliptin and the liver, and all of them put together. So from your experience, how much do we trouble our livers in the country?
Yeah,
And how do we
and
trouble them pharmacologically?
I would add one more thing: the malnutrition. You know,
Hmm.
there is data available on 18-induced hepatitis. The risk factors are the biggest is malnutrition actually. Malnutrition itself is a very, very strong predictive factor for ATT-induced hepatitis. ATT itself is the commonest cause of DILI, that's a drug-induced liver injury. 5 to 7% of the people can have it. Yes, you keep on combining the risk factors. You add the multiplicity of risk factor, the risk would be more. So alone ATT, one, malnutrition, two, Vinda, third. Of course, the risk would be higher than the normal population. Age is itself independent criteria, but the patient is not very senior in this time.
So vildagliptin we must not start at all. Pioglitazone will be protective for the liver, but because we are
Yes.
not very sure about the retina status, I think we should give it a miss. Metformin is a calorie restriction mimetic. Now, if the patient is already calorie restricted, patient is not eating adequately, patient is not absorbing or assimilating adequately, then metformin is also going to harm the patient. It's not going to benefit. If, however, calories are adequate, patient is eating adequately, and patient is absorbing and assimilating adequately, then I think metformin 1 gram we can continue, 500 BD maybe or 1 HS. But fasting is 331 and PP is 389. So here the only method would be a basal bolus regimen. Second alternative would be insulin pump. But from all practical points of view, we should tell the patient that Premixed is a good drug to use. We have been trying twice daily in a reasonably okay dose, though it is 16 units per day for a 50 kg patient. So that is zero point 0.3 units per kg body weight. We have been trying, it's not working. Novamix is okay for a straight drive. But if you have a hilly drive, ups and downs, it is better to shift to basal bolus. Let us bring down the glucose. And once you've sorted out your tuberculosis, once you've sorted out the sugar, and both are going to help each other. If we give you good glucose control, the ATT will work better. There will be no hepatic toxicity also. And if we control your tuberculosis, glucose levels are going to come down. So the insulin will also come down. The insulin requirement will come down. So let us just climb the mountain with basal bolus. And then when we come down, we can always de-escalate. In this patient, maybe 16 units we are giving and we are nowhere near control. So we can go up to 24 units. If I were to give 24, I would start 12 units of basal and maybe 4 units thrice a day. And as the TB improves, actually appetite will go up. And then the insulin requirement will also go up. Tell the patient about this. Tell the patient to feel happy when this happens. Otherwise, they will come back and fight you. So how he says, and this is from agricultural belt where Pavan and I both belong to. So we say that you are growing wheat or rice or sugar cane, whatever it is that is in season at that time. So what do you do when you grow rice? You give more water and you give more fertilizer. You want the rice plant to grow tall, and you want to be able to give more water and rice after a month or 2 months because that is a sign that you are going to get a good yield. The farmer will not feel happy if the rice plant doesn't grow, and if the rice plant does not require fertilizer, he won't feel happy. So similarly, we want you to grow, we want you to gain weight, and the insulin is like a fertilizer. It will help you grow stronger, it will help you fight the tuberculosis. Once you explain to the patient, then they stop arguing and fighting with you. So This is an important part of diabetes practice these days. You have to preempt the arguments and possible irritation that your patient may have with you. Dr. Pavan, does that happen in gastro practice as well? So the
Yes.
question is counseling, preemptive counseling, so that your patient feels satisfied.
Yeah, sir. I mean, it's not about only fighting. It gives you patient improvement out in outcome as well.
Yes.
I've seen a lot of improvement in patient outcome if you really counsel. I mean, it doesn't require a lengthy counseling sometimes, only 5 minutes or 6 minutes of counseling regarding the basic pathophysiology and the reasons behind them actually helps. So it gives you mutual benefit. I mean, you also get benefited because the patient improves, and a patient, of course, gets the benefit. And of course, the psychological picture, family, everybody feels happy. So we do a lot of counseling, sir.
So maybe like for H. pylori treatment, investigation, you tell them why you are doing it. You explain to them what H. pylori is. As a doctor, for you, it's a live thing. But for the patient, they don't know what's being done.
Hmm.
And then when you begin the treatment, there may be an initial, loss of quality of life with the medicines that
Medicine, yeah.
Dr.
Especially
Pavan
clarithromycin.
prescribes. Yes. So you tell them there's a difference between speed and velocity. For the first 5-10 days, you may feel unwell, but in the long run, you will be better. And same for anti-tubercular treatment, we do the same. Same for insulin. Patient may have neuritis initially or edema initially for a week or so, but in the long run, they improve. Uh, Dr. Muke has a request. This patient that he described, the one with low iron, low ferritin, and good hemoglobin, the patient is on regular PPI for the past 14 years, which means that at least we are sure that Dr. Muke is a great doctor because the patient is sticking to him for the past 14 years. So that is an achievement. B12 is also normal. So you mentioned that B12 deficiency would be more common. Now, hemoglobin is also increasing. So should I continue giving iron orally? As a gastroenterologist, we are asking you, what are the indications for intravenous iron in gastroenterology? And what are the indications for liposomal iron or nanotechnology iron in gastro?
Actually, I had algorithm which I showed. So basically, once you diagnose the patient with anemia, which by definition in India, or WHO definition actually, the less than 13 in men and around 12 in women, especially the non-pregnant women. So you actually divide into three. If the hemoglobin is less than 7 and patient is having symptomatic anemia because of that, that means fatigue, headache, heavy headedness, the breathlessness, dyspnea, etc., and you want a very fast relief, because then you give IVR. The ultimately hematological improvement with the oral and IV is same. So if person has good hemoglobin, that means he is an anemia, but the hemoglobin is from around 7 to 12, or he's able to take or tolerate iron, especially the tolerate iron, the IV may not be indicated. We believe in finding the cause. You should try and find the cause parallelly, try to treat the cause. So indication of IV iron are, if you really want to get faster relief, faster actually relief mean, I won't say it's a faster correction of the iron deficiency, and there is poor tolerance to the oral iron. These are the indication to give IV, because there's some risk of anaphylaxis, so we actually don't give like this. So these are the indication. Same way, I mean, the I would say finding the cause is the most important thing which one should go. I always tell my patient that it's like a tank. If it is a leak, try and find a leak rather than filling it with the water, because that's more important. That will give you long lasting benefit as compared to just supplementing the iron.
So in a nutshell, if your patient has severe anemia, if your patient has symptomatic anemia, and if you want swift redressal of the anemia, these three S's, then IV iron would be indicated. Otherwise, you go ahead with oral. If with oral, there is a suspicion of adverse events, patient is not able to tolerate. That would be the fourth. Patient is not able to sustain oral therapy because of side effects. So side effects
GI.
of oral is the fourth S. And usually they are GI side effects. Then again, you can shift to IV iron. So four S's: severe, symptomatic, swift redressal, and side effects with oral drugs. With this, Dr. Pavan, we'd like to thank you. You've made such a complex topic so interesting for us.
Thank
And
you, sir.
on behalf of Iron Talks and from doctors across the country, we thank you for your expertise. We thank you for the time that you've spent with us. Thank you. And I'd like to invite Mr. Basu from FDC to deliver the vote of thanks, please.
And Dr. Pawan, at the outset, I would say here that you have really empowered the iron talks with your deliberations today, and we are very sure about the good combination today we could find today, along with the endocrinologist and the gastroenterologist together to handle a complex situation of iron talks. And we also see that this is an ongoing session with Dr. Kalra, which we have been running for last 3 years on 52 weeks essentials diabetes essential with Dr. Kalra. I'm sure, sir, many a times we will find where would we need your help as a gastroenterologist, sir, and we will be happy to see you again back in some of the sessions with Dr. Kalra being in our platform, sir. With this, sir, I thank you, sir, and also at the end, I thank Dr. Sanjay Kalra for once again getting his time out for another week with us, sir. Thank you, sir. Thank you, Dr. Pawan. Jai
Thank
Hind.
you.
Jai
Thank you.
Hind.